In Klippel-Trenaunay syndrome, also in addition to having the capillary and the lymphatic malformations, they have venous malformations and varicosities. This is a low-flow complex combined vascular malformation. There is no arteriovenous, there is no significant arteriovenous shunting, and they have anomalies of the deep veins which can be hypoplastic. They can actually be atretic as well, and they can have venous incompetence and chronic venous hypertension in their extremities. They can get venous aneurysms which affect the deep and the superficial system. This boy here has got a superficial venous aneurysm, which you can see on the venogram here. Another patient with a large superficial venous aneurysm here. They can actually get what we call a persistent embryonic veins in the legs. The commonest persistent embryonic vein is the lateral marginal vein of Serville, and Serville was a French pathologist, and these are superficial veins. They're abnormal, the walls are not normal veins, they're valveless veins, and the lateral embryonic marginal vein of Serville runs along the lateral aspect of the leg, hence why the varicosities in Klippel-Trenaunay syndrome are often located on the lateral side of the leg. And there is another embryonic vein you can see in KTS called the sciatic vein as well. And the varicosities that we see in KTS become more apparent with increasing age without any question. And the venous malformations, like other venous malformations, can occur in soft tissues and also can be intraosseous as well. So here's a teenage girl with KTS in her left leg here. You can see here's her geographic port wine stain. Here are her lateral varicosities. And she was actually having significant pain in her leg. She was wearing a compression stocking, and I must say most patients with KTS do not require invasive treatments at all. The mainstay of treatments for most patients with KTS is actually wearing a compression garment if they have venous problems or they have chronic swelling of their leg, and the other issue that needs to be addressed is the leg length discrepancy. Those are the two commonest things that we deal with and manage in KTS patients. So here's the primitive vein, the lateral embryonic vein of Serville in this boy who had lateral venous aneurysm, superficial aneurysm. On a venogram, here's the lateral vein running up the leg. There is some drainage, you can see back into the femoral vein. Commonly we see drainage through transgluteal channels into the iliac venous system. The lateral marginal vein is not pathognomonic of Klippel-Trenaunay syndrome. You can see it very, very, very infrequently in diffuse venous malformations, but more commonly in Klippel-Trenaunay syndrome. And there has been a classification of the lateral marginal vein, and there are said to be 5 types. There is some variation, and you can identify these certainly on venography. We found that MR venography is not very good at evaluating the deep venous system in KTS, and conventional venography, either by injecting the foot, retrogradely catheterizing the femoral vein, maybe from the jugular root or the contralateral femoral vein, directly puncturing tibial veins, or actually directly puncturing the lateral marginal veins as well, is more useful in evaluating them. And the only reason for evaluating them like that is if we were going to go on and do any treatment, not just to demonstrate them at all. So here's another lateral marginal vein on some venography. This vein was actually filled by an injection in the dorsum of the foot. When we inject the dorsum of the foot, we put a tourniquet around the ankle to divert the contrast from the superficial system into the deep. Then, through these communicators, fill the lateral marginal vein. The lateral marginal vein is not just a single channel, it can be complex, and here it is. It's changed into this complexity of channels here, coming up superficially. This actually is the femoral vein here. Here's the greater saphenous vein. Here's the femoral vein coming up. And then this complex in this lateral marginal vein drains certainly back into the femoral vein, and higher up you get these these soft tissue venous channels coming back up into the femoral vein, and also at the upper end of the marginal vein complex you get this transgluteal channels draining back into the iliac system. Now, some people have operated and done some surgical stripping of the lateral marginal vein, particularly when patients have symptoms related to it. The problem is that symptoms often recur following this, and probably about 50% of patients, if they're having problems related to their lateral marginal vein with venous incompetence and hypertension, then they will have recurrence of symptoms, certainly with pain in 50% of the cases. And there are 4 of us actually in North America. That's in Canada. There's 1 of us in Canada, that's me, and there's 3 physicians, interventional radiologists in the US, who've done some endovenous laser treatment to the lateral marginal vein. And I'm not saying that this is the answer at all, but it may be an alternative option to surgical stripping. But because this vein is made up sometimes of multiple channels, it can be quite tricky procedure. And I must say, when I was told by some of my other colleagues, my 2 other colleagues I know in the US, they led me to believe that this vein was like a single channel and it was going to be pretty straightforward. And this is the first case I did, and it was quite a surprise. There's never a shortage of surprises sometimes. So what we did was detailed venography showing the vein, its drainage. There's a large channel coming back into the iliac system, and what we actually did with this large channel was to occlude it. But before any of this, we put some cable protection and put an IVC filter in. I'm sorry, I don't think this really shows very well. And the reason for putting an IVC filter in is because these patients, during long procedures, not just interventional radiological procedures, but if they're undergoing any type of surgery, for example, that's going to last several hours, they are at risk of major venothromboembolic events and pulmonary emboli, and there have been deaths in these patients. So if you have a patient who needs maybe a 5-hour surgery and they have KTS, the general recommendation would be to give them low molecular weight heparin for at least a month before their surgery or their long procedure, during the procedure, and for a month after their procedure, and probably also put in cable protection, temporary filter into their IVC, and then that would be removed maybe 2 weeks or so, or 3, depending on the sort of filter you use, after surgery. So we put in the filter. We then actually put in an Amplatzer 2 into this larger channel, because we thought if any clot comes out of these veins, actually this might be the channel it might try and pass through. So we put an Amplatzer in there, and then we did various venograms, and in fact we then passed the laser fiber up and lasered several of these channels. And this girl has been wearing compression stockings for about 10 years. When she takes her stocking off, she gets significant pain in her leg. She has venous incompetence and hypertension in her leg, and she actually has done quite well actually since this. Not all patients do well. So I just wanted to show you some venograms in KTS in the lower extremity, showing what you might find, bearing in mind that the lateral embryonic vein may have some variation of its anatomy and drainage. So if you try to put a catheter from the opposite femoral vein and coming down, you may actually have some surprises, because you can get iliac venous anomalies as well. You can get stenoses and atresias. So that might be one reason why you can't get your catheter down from the opposite side. So you may want to actually come down from the jugular or directly puncture the common femoral vein itself. And in this child, there was atresia of the femoral vein. This channel here is not the femoral vein, actually. It's this, and it's part of the embryonic vein running in the front of the thigh here, coming down. And every time we actually put a catheter and a wire down, it came down this channel. I couldn't identify the femoral vein, and in fact this is the lower end of the femoral vein here, and we're filling all these other channels. So this is what you sometimes see. The femoral vein can also be hypoplastic.